Idaho. Once you're down around 10 degrees, it doesn't make much difference. You just add an extra layer of clothing. Cover your face and your ears.
Oh, I see.
It's a bad time to have no hair when you've gone through chemo.
Oh, man.
Need a nice wool cap.
Yeah, that's right. So what did you...
I'm like you, Rick. I'm a wuss with the cold.
Oh,
if it's 40 degrees, I'm freezing.
I hate it. My fingers are so cold. Even now, my fingers are cold. It's not good. Not good.
40 degrees is a warm bath up here.
I know. I know. That's why I told you. You'd be telling me to, you know, take my shirt off and just enjoy it, man. But no. I couldn't do that anymore. Could not do that anymore. So,
if I could get out of here, I would.
No, hold on.
I got one comment for you guys, and
yeah,
maybe it won't make much difference, but I've heard from Ron Steinbach, and he's in pretty bad shape with his kidney and infections in his kidney and
I know that Rob speaks to him almost every week.
Okay. I just, anybody that's been talking to him, I give him a call and give him a little encouragement. He sounded terrible yesterday.
Yeah, I know Rob talks to him frequently, and I think he's undergoing chemo, isn't he?
Yeah, they actually did one round. They're doing another round, but he sounded like, well, you're supposed to drive to Denver today to do another. He started another round of it.
Mm-hmm.
He didn't even know if he could drive to Denver from Gillette, where he is. It's
right.
An 8-hour. Yeah, he just sounded like he's just miserable as hell.
Well, you
he
know,
wasn't whining about it. He's just hurting.
Yeah. No, I mean, I've told Rob, and I think I told you, that he's welcome to join these groups, provided he doesn't ask anybody for their phone number.
Yeah, I got you.
And
he sometimes shows up on Tuesday nights, but not very often anymore.
On Thursday nights, you mean?
Thursday nights.
Yeah.
What's his name, Frank?
Ron Steinbach.
Ron Steinbach.
Oh.
So, yeah, you know, I just, it's not fair for him to, it's not fair on the other participants who don't know him, and he asks for the number, and so, you know, if he needs to talk to more people, we'll connect him, but he can't just come on here and ask for it, because it just doesn't work for other people. It puts them in a very difficult situation. And that's the only condition I got to impose. And, you know, I don't have to do that very often, but that's where we are. Anyway, sorry, go ahead.
Anybody that's got a connection to him, just if he could give him a call and encourage him. Nice.
Okay. Okay. So let me see who I have here. I can see, on the list, I can see Jake, Len, Paul Frieda, Skip, Maniscalco, Eric, Bookbinder, Bill, Franklin, Frank Kelly, and who else is on that I haven't called?
Yeah, that's Korea.
Oh, how are you?
I'm doing good.
Okay, Dennis. And who else? Anyone else?
Ben Gulo.
Ben Gulo, I was just thinking about you. How are you?
That's why I called.
Yeah.
I'm doing good.
Good.
Start radiation on the 3rd, on Wednesday.
Oh, okay.
Yep.
So we'll definitely talk to you a little bit about that. And anyone else? No?
By the way, Wednesday is the 4th. I've got something going on Wednesday, so whoever just said the 3rd there might miss their radiation.
Yeah, that's right. It's the 3rd. Sorry.
Okay. So, let's see. I've still got, well, I've got a few people I can't identify, but we'll figure them out as we go along. So we don't have anybody new. So let me run down the list and see who has something to talk about, and we'll dive right in. Jake, how about you?
No. Next time I will. I'll have my blood test back to see how my Casedex cessation is working or not working.
Oh, okay. Yeah, that could be interesting to hear. Len,
Yeah.
how about you?
No, thanks, Rick. I'm good.
Okay. Paul Frieda, anything for you?
Yeah, I have a couple questions.
Okay. Skip, how about you? Oh, it looks like
I just
Skip.
saw a message that said Skip left. Skip left the meeting.
Yeah, I saw that too. He's sort of on, I think he's in and out. I think he's having trouble figuring out the best way to come in. But we'll see. My guess is he'll be back because he has something. I know that he has something he wrote to me about that he wants to talk about. So I'll look out for him. Eric, how about you?
No, and I have to leave early, so I'll be gone probably around 5.
Okay.
Around 6.
Okay. Okay. This halo effect is very impressive, I have to tell you. Bill Franklin, you put something in the chat box. Tell me what. Yeah.
Yeah, I don't have the link I had was really, really long, so I just put the title of the study. Something I came across this week.
Yeah.
They diagnosed 17 different diseases with by analyzing the breath of a bunch of like over 1,400 patients with fairly high accuracy, and prostate cancer was one of the listed diseases. So I just thought maybe someone might want to read it. That's the title. If you search on the title of the study, a bunch of links will come up.
Well, you know what? Let's come back to you. Maybe you can tell us a little more about the study and
yeah.
what they did. So we have time, so we'll come back to you.
All right, and I had a question too.
Okay, absolutely.
Actually, since Eric said he's leaving early, I was thinking of something. Not that I walk around all week thinking about you guys, but this just popped into my head when I was reading about the bipolar study again. Because Eric, we were talking about some of your issues with fatigue and shortness of breath, and we were wondering if it was ADT that was causing it. Have you ever thought about just getting a shot of testosterone and seeing if those symptoms go away? Since they're doing the bipolar stuff and they're saying there's not a big impact of the shot while you stay on ADT, but you get the benefits of the testosterone. I don't know. I was just thinking about it.
But it's a good thought. I think that the problem is that I'm in the middle of a trial, so I'd have to get their approval.
Yeah, that might mess up the trial's results.
Right.
Well, let's maybe if we've got time again, we can talk about that, and when if Eric is still with us. Okay, Frank, how about yourself?
I think you could put that differently.
So, yeah, it was a little indelicately phrased. I beg your pardon. Forgive us. Frank, Kelly, anything for you?
Yeah, I got something to add if they want to know a little bit about the bipolar treatment.
Okay,
finished it.
Absolutely. Dennis Career, anything for you?
No.
Okay. And Ben, are you back with us?
Yeah, I'm back.
Great. Okay. So we'll review with you where you're at and your radiation treatment.
So a little over a year now on
Hold
hormone
on,
therapy, and
Hold on.
they're going to start.
Hold on. We'll come back to you. I just want to get for timing. So we will review with you if is that good by you?
Oh yeah, absolutely.
Sure. Okay. We'll come back. We'll come back in.
Yeah, and also I think Wednesday is the 4th, right? Yeah, Wednesday is the 4th.
Wednesday's the 4th. Yeah. Yeah. Okay. We're just sorting calendars out here, but Wednesday is definitely the 4th. And is there anybody else that I haven't? Has anybody else come in? Because I've seen people coming in and out. Skip, are you back with us?
Yeah, no, I'm on.
Okay. Skip, we'll talk about the genetic testing that you wrote to me.
Okay.
Okay.
I appreciate that.
Pleasure. And anyone else? Have I missed anybody? Okay. So let's kick off with Paul Frieda. Paul, you had a couple of questions.
Yeah, okay. I just like opinions on the clarification of what my tumor cells are doing. I just finished 1 year of Lupron. Went on it when the PSA was starting to rise, and it got up to about 3, about a year and a half after my prostate surgery. So I'm wondering, since my PSA is below 0.1, does that mean the tumor cells are all dead? Or does it mean they're just sitting there idle and they're not replicating? Or does it mean they're not replicating and they're just not putting out any PSA? I'm not clear on, you know, what they're doing. I mean, is there an accepted understanding of what's going on when you're in remission due to Lupron?
I mean, that's a really good question. I mean, there are a lot of people that say that the Lupron just puts your cells, makes your cells dormant, makes the cancer cells dormant. And that when you stop the treatment, the cancer cells come back to life. But at the same time, we know that for some people, Lupron can be successful in killing off the cells where there's micrometastasis. So to me, and this is not a medical opinion, and this is just my own impression, and you know, I stand to be corrected, but to me, I think what happens is that initially the Lupron makes the cells dormant, and then if you continue the Lupron for long enough so that you starve the cells for a long enough period, then eventually those cells they die off. Now, is a year long enough to do so? Probably for me, my view is it's on the margin. And that's really anecdotal, having seen people who have tried and got off of hormone therapy because they couldn't tolerate it, versus people who tried and stayed on for the course of treatment. And the course seems to indicate at least 18 months. So it's a really good question. And I think you could say either way. They could be in remission. They could be in remission in the sense that they're just dormant and ready to come back, or they could have died off. I don't know. But let me open it up. What do other people think?
Well, this is Skip speaking, and just my last meeting with Dr. Schultz at Prostate Oncology Specialist, he suggested that the maximum, you really need to get 18 months of Lupron, and that anything more than 18 months really isn't adding anything to the overall effectiveness of the Lupron.
Mm-hmm. Well,
And
that comes from a recent study, Skip, where they published in 2016, where they said that 18 months, that there doesn't seem to be a lot of difference between 18 months and 36 months.
correct.
Before that, one of the earliest studies, which probably goes back about 8 or 9 years now, said that 28 months is better than 4 months. And then there was another study that said 36 months is better than 12 months. But we never really knew what the optimal period was. But now we know that it's more than 12. And if 18 is the same as 36, 18 probably looks to be about right. But there are still doctors out there that are putting their patients on 3 years of hormone therapy, which is an awful lot. Now, I will also say that this is for people, before everybody says, well, you know, why am I on it for life? This is for people who are getting hormone therapy as part of their initial treatment. And those of you who are getting hormone therapy because your treatment failed and who are looking at long-term use of hormone therapy, my feeling is, and I haven't read anything about this, but my feeling is probably if you want to consider intermittent, don't look at intermittent until you've done at least 18 months. Len, that's time for you to chime in.
My doctor at Sloan Kettering had me on intermittent after just about 10 months of ADT. And, you know, the PSA came roaring back. So I'm not sure that was such a good idea. But now I've been on, I think, 14 continuous months of ADT. And as I mentioned last week, I'm going to be starting Zytiga according to Dr. O at Mount Sinai, to hopefully get the PSA level down to undetectable from where it is now at 0.1, because he said those are the cells that are resistant. Now, to answer the question, though, I asked him the same thing. I said, does hormone therapy actually kill prostate cancer cells? And he said yes.
Yeah, my doctor said that too. That's one of the reasons. I had previously had the understanding it just puts them in a dormant state, but my doctor, in discussing it, just casually said, he said, you know, it kills the cells. Now, I don't know if he was speaking carelessly. I didn't go into an intellectual examination with him, but I was really, you know, taken back when he said that.
But the two aren't inconsistent.
This is Skip again. My understanding is that it doesn't really directly kill the cells, but it starves the cells and stops them from reproducing, and then they die off in their normal process of apoptosis.
Right. Right.
But they don't all die off.
Those graham crackers?
That's my understanding as well. That doesn't explain the cells that always come back.
Yeah.
I think it's a combination of the two things. Some of the cells are killed, but some of them remain dormant, who are not killed, and then they are the ones that develop the resistance. Because obviously, for prostate cancer to come back after 2 years or 3 years on hormone therapy, it means that they're not killing all of them. So my understanding is that it's a combination of the two. Some are killed, some are just made dormant, and they are the ones that eventually come back with a resistance.
Yeah, that does sound reasonable.
Because otherwise, Zytiga or abiraterone or any of those would kill the cancer and get you down to zero. And most of us never get down to zero. Never have, never will.
Mm.
Well, I think it's also generally accepted, though, that right from the get-go there are some cancer cells that are hormone resistant. And, you know, once you kill off all the ones that are hormone sensitive, then you're left with the hormone resistant group. and then treatment becomes difficult.
Right. But even those that are hormone resistant are not hormone resistant right off the bat. I think it's only after they develop their own way. They develop a way of feeding themselves, creating their own testosterone. But for a time, they are kept dormant.
Yeah.
But they never go away completely.
So what I'm thinking is that since there's a second colony of resistant cells, that seems, perfectly logical to do some chemotherapy, because maybe the chemo will kill that colony.
Well, I mean, that's maybe the reason why early chemo seems to show better results.
Right.
It clearly does. Do we know how early? Do we know whether somebody should get chemo immediately on recurrence? Well, there's no evidence so far, but there are doctors who will give you chemo very early in the process, right, Skip?
Yeah, in fact, my treatment is kind of patterned after the Stampede trial. So I went through 2.5 months of ADT, then went through radiation therapy, and then 4 weeks later began the chemotherapy. Although the Stampede trial, I think, calls for 6 to 9, or 4, well, I can't remember, 4 to 6 or 6 to 9, up to 9 doses of Taxotere, docetaxel. I stopped after 4, and the reason I did is because I didn't have any evidence of any metastases or extracapsular extension, and the medical oncologist felt that given the side effects I was experiencing, that it was safe to stop after 4, and he deemed that the 4 treatments was really giving me 90% of the effective benefit of the chemotherapy, and I shouldn't torture myself for the last 2 doses, so I did stop it early. But that was the pattern that the trial that the medical oncologist is following with me, and I'll continue on to ADT now for 18 months. And so far my PSA has been 0.06 for the last 4 or 5 measurements, and hopefully it'll stay there. Time will tell.
I think, I'm not certain, I'm just sort of looking as we talk, but I think the Stampede trial was designed for recurrent, and I don't think there was anybody in that Stampede trial that was a high-risk diagnosis.
Well, it was either Stampede or Chartered. One of those 2 trials, there was about 90 people in the trial that were considered high. They were just considered high risk.
Right. Okay.
Yeah. So there was one of those trials had this. I'm sorry?
It would have been Stampede. I know that there were a lot of arms in that Stampede trial. I didn't realize that there was one arm that was people that had a high-risk diagnosis. But yeah, it makes sense. It makes sense.
Yeah, there were about 90 people in one of those 2 trials that were just high-risk diagnosis.
Mm-hmm. Okay. Okay.
And it did elevate the rate of non-recurrence, as I recall, by about 8% from 70 to 78%.
So Paul, it might be worth reading through that Stampede trial. There's a bunch of places you can find it online. There's a lot written on it. There's been a lot written on it by Mike Scott on New Prostate Cancer International. It's easy to track down the information on it. And there's going to be an arm that was probably close to your situation. And you might want to look and see what, if that arm, if they employed chemotherapy or not. But yeah, I mean, your thinking is right. If you're willing to endure the chemotherapy, then it might make a lot of sense. you know, we don't know to what extent it made a difference for Dominic, God rest his soul, but he lasted 10 years after his surgery. And he had recurrent, you know, his cancer was right there immediately after his surgery. And he was in that trial back in 2005, I think, with early chemotherapy. So one would not have expected that sort of overall survival with his situation after his surgery. We don't know. We don't, you know, we don't know what it was, but it could have made a difference for him.
Yeah. Okay.
So every one of these cases is different, and every patient is different, and you know, we try to put ourselves inside the parameters of these trials and figure out how they're going to benefit us, but they're only averages, and they're only statistics, and you just don't know how you're going to respond at the end of the day.
Right.
Right.
Bingo.
Did you have another question, Paul?
Yeah, that's my basic concern this week.
Okay.
Thank you.
Sure. Let's go on to Ben Gulo, because we haven't heard from you for quite some time, Ben. Fill the guys in on your situation and tell us where you're at in terms of the radiation therapy starting this coming.
Starting on Wednesday, yeah. So a little over a year into my, you know, hormone therapy at ADT, I have been doing very well overall. Had to go on some depression medicine because I was going mood changes quite a bit, and that's really helped. But Dr. Harstak decided that now it's time to do, you know, focal radiation on the prostate and also on the metastasis, that's the small spot in my hip area. So I start that on Wednesday. I mean, overall, I'm knock on wood, I've been doing very well. She's very happy. My PSA is undetectable. And after the radiation, she's talking about going on to a peripheral hormone therapy, which is not as severe as Lupron and Casodex. So I'm kind of looking forward to that to get off some of these side effects of the current ADT with Casodex and Lupron.
Mm-hmm. So, so you're going to do, this is really interesting, that you're going to do some focal radiation, and that's going to, so we should tell the guys that you haven't had any radiation to date, and you haven't had surgery either, correct?
That is correct.
Right. So, so they now are thinking that maybe they should radiate the prostate as well as these spots?
Correct. Yeah, she says that because my prostate and lymph nodes have significantly gotten smaller since my first diagnosis, now would be a good time to go ahead and radiate and see what happens. Excuse me.
Okay. And so what radiation are you going to do? You're going to South San Francisco, is that right?
Well, no, I'm going to Oakland.
Oh, you're going to Oakland?
So I'm going to, yeah, going to Oakland, Kaiser. And then 6 weeks, I go to like February the 6th or so, or 7 weeks,
Mm-hmm.
you know, Monday through Friday.
Mm-hmm.
And then we'll see what happens. I'm just, you know, kind of concerned about side effects since I am working full time, and I know that the first few weeks is not going to be very much noticeable, but I guess from now on the fatigue really kind of sets in.
Well, I mean, one thing for sure, and I know it sounds counterintuitive, but you've got to be doing 10, 15 minutes walk every day. You know, keep that exercise routine up as best as you possibly can, because that's going to help you a great deal with the fatigue.
Yeah,
Particularly,
I'm still working out twice a week. I mean, I do that significantly. I walk at work so much as it is, but I am, doing cardio workouts and weight bearing, weight lifting twice a week.
so the weights are really important because of the ADT, but beyond the weights, what happens with the radiation when they focus on your pelvic girdle, which it sounds like they're going to be doing, is that you have a lot of bone marrow in your hip area, and so it can depress your blood count a little bit, not significantly, but it can, and that's one of the reasons why you get tired. So a good way to sort of combat that is to try and get 15 to 30 minutes aerobic in every day. And a good way to do that, if you don't have the time, like you're working, is if you've got an exercise bike at home, that can be very helpful. So just a thought.
Okay.
Or a step machine at home, or anything that you've got that you can
do
stick in
aerobics.
front of the TV and just keep moving whilst when you get home and you're relaxing, or you get up early in the morning, whatever works for you. I mean,
Okay.
that was my experience with the radiation. Anybody else? I mean, it's really interesting. I would say as recently as a year ago, they would never have radiated somebody like you. And it's really intriguing to me that that now they'll look at radiation for someone who they recognize has got advanced prostate cancer from the outset. It's really, really interesting. Are you they haven't seen any, or have they seen any bone mets or not then?
Well, they had the bone mets in the hip, and there was one small one in my left part of the skull.
Mm-hmm.
And the one in my left part of the skull has diminished enough where they feel that they're not going to worry about it. They're going to watch it, but they're not going to worry about that.
Mm-hmm.
At this point, as long as I'm staying on hormone therapy, and
right.
Even when I transfer over to this peripheral hormone therapy, she's not gonna worry about it. Just keep an eye on it. If I was to stop radiation, if I was to stop hormone therapy altogether, because the side effects are just too much and my quality of life just sucks, then she was talking about possibly doing CyberKnife radiation on the skull.
All right.
But she's not a real big fan of that, just because the brain tissue and stuff like that.
Right. When I'm not quite sure what she means, or what's meant by peripheral hormone therapy. Do you know what drug she's talking about?
Yeah, I was listening to her. I recorded our session last time, and she mentioned some over-the-counter drug. It would be Casedex and something else. It wouldn't be the Lupron.
Okay.
So,
yeah.
Probably Avodar.
Yeah, that's what it was, Avodar.
Yeah, Casedex and Avodar. Okay. Okay. Well, anybody else want to talk to Ben about this treatment?
Well, Rick, as you well know, I was terrified about getting radiation therapy because of side effects, but eventually relented with all the pressure from you and Dom, and I was shocked to find out that I got through it very easily with very few side effects. So, you know, Ben, don't worry about it so much.
Well, I'll tell you what, that's great to hear. I was hoping to hear that, you know, from somebody that, you know, saying that it's not all gloom is doom. I mean, when I went in there for my first, what is it, where they tattoo you, my first tattoos I got in my life, and then I was sitting waiting to go in, and I'm sitting with the other patients that have been going through radiation. I was just terrified because they just looked terrible and they didn't look healthy, and I was like, oh my God, what am I going to put myself through here? But theirs weren't prostate related. It was, you know, some other type of radiation they were receiving, but they just looked terrible. But it's good to hear that maybe it's not as bad as I think it's going to be. Right.
Yeah, go into it positive, and I expected to have fatigue, but I didn't.
Well, that's what I'm hoping. Yeah, that's what I'm hoping. Yeah.
Yeah.
Yeah, I did 28 sessions of radiation, and to be quite honest, it was I had really no significant side effects at all to speak of. I got toward the end, I got a little bit of fatigue, and the hardest part of it was just, you know, the temporary hemorrhoids caused by the balloon and so forth. But other than that, I had really nothing to speak of. And most of the guys who went through radiation at the same time I was going through, you know, we were all one after the other, 20 minutes apart or half an hour apart. Everybody had the same experience to share, and that was no side effects. So I think you can probably feel very safe and very comfortable that you're not going to suffer as a result of this.
I'm going to ask.
Yeah, I mean, I know that attitude is, you know, will determine your altitude. So I'm, you know, I'm very positive going into this, and I want to get it done. And it was good to hear from you guys that the side effects are maybe won't be as significant as I think they're going to be.
Yeah, and a lot of the people that you see getting treated for radiation aren't there for the same treatment that you're going to be getting, you know, aimed very specifically at your prostate cancer. Some of them have other serious, very, very serious cancers, and probably very extensive cancers, and probably been in treatment for a long time. You know, I saw some of those same people, and it's very sad, but it certainly wasn't the people that were being treated at the same time for prostate cancer.
Go ahead, Jake.
I just wanted to ask Skip, what balloon are you talking about? That's a new one.
Oh, I had proton radiation, and they actually insert a balloon in your rectum to protect the rectum from the radiation. The balloon is then filled with water.
Oh, okay.
Yeah, and you know, it's just the 28 sessions of in and out of that balloon. It's, you know, that part of it can be a little irritating, but other than that, nothing.
Well, Ben, now they have something better than the balloon, which is they call it space or hydrogel. It's a hydrogel they insert between the prostate and the rectum to protect the rectum. And I had that done. I had no rectal problems. Of course, I suppose there's always the possibility of late problems, you know, like a year or 2 years out or more, but certainly no acute problems.
Yeah, I was going to...
you should ask for that.
I'm sorry. Yeah, they're telling me that I have to drink 32 ounces of water prior to the treatment to get my bladder full, so it will protect my rectum and bowels.
Yeah, we had to do the same thing, and when you go in, they actually measure the amount of water in your bladder, and they'll either say drink a little more or go release some, because they'll determine the exact right amount that's best for your physiology. And so So I think we all go through that, as well as some of us go through the balloon or get the gel, and I guess it depends on the radiation and where you're being radiated and so forth. So all that gets taken into consideration. Also, I think in some cases too, at least my radiation oncologist did say that it's possible that a year and a half down the road I could get some temporary rectal bleeding, but not to be alarmed by it, and it can be just treated by my regular primary care physician.
So a couple of things, Ben. The first is that I don't know whether you can get Kaiser to give you this gel. It's called Space Ore, I think. Is that right, Ben? Is that right, Len?
Yes. Space OAR.
Yeah. I don't know whether you can get them to give it to you, but if you can, I would definitely recommend it. You know, I didn't get it, and I think as a result, I've had a lot more issues than I probably needed to have, but I didn't get it because it wasn't around at the time.
So it's called Space
Ore, OAR.
Space Ore. Okay. And then, now, how do you take it? What's the prescription for it?
No, it's an injection. They put you under anesthesia at the same time that they're putting in the. Did they talk to you about fiducial markers, gold markers to locate the prostate?
No, all they put like 3 tattoos on me on the exterior of my body.
Right.
But didn't talk about anything else.
Hold on a minute.
That's for the mold.
Yeah, but they.
But they'll also.
They didn't. Sorry, Len, but are you saying that they didn't put gold fiducials in?
Not to my knowledge, no.
You know, it sort of concerns me because I don't think the equipment that they're using in Oakland is as up to date as the equipment that they have in South San Francisco. And I didn't want to say anything to you because I know how much more convenient Oakland is than South San Francisco. But if they're using old equipment where they're not even putting gold fiducials in, I would have a real concern, Ben.
And what is it called? Gold what?
Well, these are little gold seeds that they actually place inside the prostate, and it allows the equipment to triangulate on these seeds, and so it becomes a lot more accurate. Now, if all they did was give you the 3 little tattoo dots, did they make a body mold for you?
Yes.
You know, I mean, this is old equipment, and if it were me, I wouldn't be going there. I would be going to South San Francisco. But you know, you're so far into it at this point, I don't know what to tell you. But
well, I'll talk to the doctor or the radiologist is the chief at Oakland. So
what's his name?
And we it's recommended by Harstag.
Yeah.
So, well, yeah, I don't have it right here in front of me.
Because it's convenient. You know, to me, I would be going to Joe Song in South San Francisco, or there's another guy down there whose name, an Indian guy, Mohan, I think it is, also in South San Francisco, who's very good. They're very experienced with prostate cancer. But the point is that their equipment is much more up to date. And I think what you've got to ask them candidly, and you want a real candid answer and not a BS answer, is what's the difference in the equipment between what you've got here and what's over in South San Francisco?
Well, now Wednesday, my first treatment, I meet with the radiologist. So I'll definitely ask those questions. And if he says, hey, the equipment in South San Francisco is better, I said, well, let's stop right here.
Well, I think it's something that you really need to consider. And if he's going to refer you, you tell him you want to see Joe Song, who I've referred to a lot of people, including Steve Bornstein, who isn't on the call today, who's a Kaiser physician himself. He probably has some knowledge of the difference in the equipment, knowing Steve. But yes, I mean, you know, a lot of times they'll refer you to the hospital. Like in my situation, now again, this was back in 2007, but I was in Kaiser San Rafael, and they said, oh, well, we'll send you up to Roanoke Park and the equipment there and what have you. And I said, well, is there anywhere else I could go? And they said, well, if you want, you could go to UCSF. And I said, I'm going there. They didn't, that was it. I said, just put me in there. And that's how I got into UCSF. At the time, there was a contract. That contract is now no longer in effect because they built the new center in South San Francisco. It's just north of the airport. And the equipment in South San Francisco is really good and up to date. And, you know, Andrea's going to send you, she knows that you're in Discovery Bay. She knows that you work in Fremont. And so, you know, she's not going to schlep you all over to South San Francisco. But I think you've got to be comfortable with the equipment that they're using for you in Oakland versus the equipment that they might have in South San Francisco, where they definitely would be implanting gold fiducials. Now, when they put those gold fiducials in, I'm going to hand back to Len. What do they do, Len, with this spacer?
Sorry, I had to unmute myself. Yeah, at the same time that they give you general anesthesia to insert the gold fiducials, they insert the hydrogel. So it's done with a needle, and they inject it between the prostate and the rectum, and it creates a space between those two organs. So, you know, it's all done very quickly. It's, I think, you know, 20 minutes maybe. They give you propofol and you wake up feeling great like Michael Jackson used to. And, yeah, but something's strange there that they're not using the gold markers for your prostate because the prostate moves around, and the equipment needs to, as Rick said, triangulate on those markers, you know, in order to be very accurate.
Well, I mean, it's not that it's strange, Ben. I mean, it's that they're using old equipment. There's a lot more recent techniques that are available.
Well, yeah, I'm surprised to hear that, but I'll definitely ask that question. They did do 2 CT scans to make sure that they had, you know, the plan to do the treatment area, but never mention of any type of gold seeds or fiduciary.
Yeah, yeah.
So I'll have to ask that question.
Yeah, I think you do need to, and you know, don't hesitate to call me also. But yes, I if it were me, I wouldn't be doing it without. If I didn't have either gold fiducials or the other equipment that Kaiser doesn't have it, but the other equipment they use is there's a machine called the Calypso machine, which is made by one of the other manufacturers, Varian, I think, and they implant these kind of transponders, which are like the they're like the passes that you use to the you know, on BART in your car, and the machine constantly sends out a signal which bounces off of the transponder, so they know all the time exactly where you're, even as you're breathing. Whereas with the gold fiduciaries, they regulate the machine every few seconds. They re-regulate the machine every few seconds. But I don't know that there's a significant difference between those two types of treatment. But I mean, I had, going back to 2007, I had gold seeds implanted. So, you know, now, as far as the spacer is concerned, that's going to be a fight to get it at Kaiser, but my guess. But if it were me today, I would be doing everything I could to get that, largely because I've had issues as a result of the radiation. So I think that anything you can do to create that gap to protect the rectum is important.
Okay, well, that's great information. Thank you, guys.
Pleasure, and feel free to call me back. I mean, frankly, I might get on the I might get on the horn or send a note to the guy in at Oakland tomorrow and start this discussion with him right away, because they really need to be candid with you. If you call Andrea and ask her, she'll give you an honest answer as to how much better the equipment is between one or the other, and the difference between putting in the gold fiducials, which they do in South San Francisco, and whatever Oakland is doing. But this Oakland equipment sounds pretty antiquated.
Okay.
Okay. So Ben, keep me posted. Give me a call or let me know how I can help you. We'll move on to Skip. Skip wrote me and asked me how and when should we use genomic testing. And Skip, I don't know if you had a chance to listen to any of the previous conversations we've had about that. We've had some good conversations. But if you want to be a little more specific, we can try and answer you as best as we can.
Well, I guess the next step in my treatment, if a next step is really necessary, might likely be immunotherapy. I mean, certainly that might be one of the treatment protocols considered. But I hear a lot of negatives. I mean, there's many positives with immunotherapy, but there are also negatives. And for example, it causes damage to your liver and damage to other internal organs and so forth. So from what I've gathered in talking with people and in my reading is that the long-term goal is to be able to develop an immunotherapy specific to each patient's particular cancer, but to do that and do that effectively, it also has to be linked somehow to the genetics, and I'm not sure if that's the genetics of the patient or the genetics of the cancer cells or both, but that eventually a immunotherapy will be able to be designed for a particular patient.
Right.
So that's kind of where my question is oriented. I'm just kind of trying to think a little bit outside the box in terms of what might be in store for me, 2 years from now or 3 years from now, depending on how successful my treatment to date proves to be.
Well, the first thing I would say to you is go with the flow and live in the moment, and don't start knocking yourself out about what might be or might not be 2 years from now, because if you would have done that 2 years ago, you wouldn't be thinking about some of the options. You wouldn't even know about some of the options that are available to some of the patients today. So
right.
We don't know what's going to be there 2 years from now, and personalized medicine and genomic testing is a great example and case in point, where 2-3 years ago we just thought this was pie in the sky and wouldn't be around for 5 to 10 years, whereas today it's not difficult to get tested. Now, if you haven't listened to the second hour of the October 31st session, I strongly recommend you do, because a lot of the questions you have will be answered in that session, in that hour and 5 minutes. It'll explain to you what the difference is between inherited or germline genetics and somatic, or the genetics of the tumor itself. I mean, we can go through all that right now, but a lot of the guys have heard it before.
No, don't repeat it.
And I think
I'll go back.
I think that if you listen, it'll be very helpful. Also, in two of the old recordings, I can tell you, I've left them up deliberately because I thought that the sessions were frankly very, very good. But in two of the old recordings, we have spent some time talking about genomic testing, particularly with Bill Burhan's on the line, who is a cancer research professor. And let me just tell you, the dates on those two. If you go to if you go to the ANCAN site, there's one on August 23rd, the first one that's listed. And then there's another one on September 27th. And then on October 31st, we spent the whole session talking about genomic testing, but the first 55 minutes was more about testing for people with low-risk disease, and the second hour was talking about people with advanced disease, because there are sort of two different areas. So I think it's worth you informing yourself. But you know, if your treatment is successful, God willing, it's never gonna be an issue for you.
Yeah, I would hope that's the case.
And I just want you to live in the moment, and if things are good, then stick with the things are good. By all means, educate yourself, but don't worry. And who knows, you know, by the time 2 years from now, the technology may be so different in how we test for, how we do our genomic testing. I just don't know.
Yeah.
Who else? Anyone else on the call would like to talk to Skip about this?
Well, I'll definitely go back and look at those three sessions, listen to those 3 sessions.
I mean, go back, listen to them, and then don't hesitate to send me an email for clarification.
Okay.
I mean, one of the things that I'm working on personally is to try and figure out how to get a better protocol for genomic testing. And what I'm finding out is that we're not going to have to reinvent the wheel here, that ASCO, the Clinical Oncology Society, American Society of Clinical Oncologists, is actually putting something together. And one of the things I'm hoping to do in 2017 is to try and get some patient input. There is somebody at ASCO that is concerned with patient advocacy, and Renata Lauers, who moderates our caregivers group, has met that person, and when she gets back to her home in Virginia next week, she's going to write me an introduction or send me the name. And because there are some aspects that I want to be sure that they're considering, I don't want them to come out with the genomic protocol, which is developed by physicians for physicians without having had patient input. And so that's something that we're kind of working on. But yeah, I mean, I would say, is there a history of any cancer in your family, Skip?
Yeah, both parents. My mother had lymphoma, but my father died from prostate cancer.
Okay. No breast cancer.
No breast cancer, but my mother's sister had breast cancer.
Okay.
And, there's some genetic relationship there.
There is. I mean, if you wanted to do something now and you could get your insurance to pay for it, and I know for sure that they do this at Schultz's clinic because Peter Kafka had it done, is you could get what's called a germline test to see if you have any inherited risk. That's just a saliva test, basically.
Yeah.
But at the same time, even if you did, I don't know that it would change your treatment right now. And I'm a believer in not doing tests unless they are going to change your treatment. And even if you were BRCA positive, I don't think it would change what they're doing for you right now.
Yeah, and I guess I would always safely assume that, at least based on all the information that I have and things that doctors have shared with me, if you have a history of prostate cancer in your family, you're probably genetically predisposed. I mean, that's always been my sense of it, which is partly why I'm just trying to be aggressive about treating it.
Right. The question is what genes are disposing you, and if certain genes are present, it would make you eligible for certain treatments if the cancer returned. Okay. Well, let's keep plowing through here. Frank Kelly, you had a couple of questions.
Not really. I just, if somebody was interested in this bipolar thing, I'm done with my rounds, and if there was somebody that asked a question about the bipolar thing, I can give them some information on it.
Well, it was Bill Franklin speaking to Eric, and Eric has left at this point. He left actually about 25 minutes ago, which is why I didn't come to you before. But any updates for you on the success or otherwise of the bipolar, your bipolar protocol, which is a little different from the one that people in Johns Hopkins are doing?
Yeah, they're two different sides to it. Mine involves the etoposide, which, as I'm told, is a chemo drug you take by mouth. At the same time, you're getting the testosterone shots. They both, 14 days on and then 14 days off. It's a 28-day cycle. It didn't from day one. My PSA started to rise. It went from, over the 3 months, it went from 0.09 or 0.9 to 5.8 in 3 months. So we quit that. Originally, you said something about if it worked, from that point on, you just get the testosterone shots. But obviously, I'm not at that point to just get testosterone shots.
Mm-hmm. So where was your finishing up PSA? Did you say 3.9 or did you say 5.9?
5.8.
5.8.
So in 3 months, it did pretty well, quadrupled basically. I might have been 0.99 or something like that when I started it.
Mm-hmm. Mm-hmm. Mm-hmm.
But it kind of not quite doubling each month, but close to it.
And where are you at this point in terms of where you're going next? What are you on? You're on, obviously you're still on the Lupron or Firmagon, whatever it is he's giving you. And what any other thoughts or where are you?
Well, let's see, I saw him just before Christmas.
Mm.
And he didn't mention it to me. He just said, well, we'll have to try something different. Then I got a call Monday about getting more chemotherapy. Now, I've done the docetaxel, whatever the other one is, toxo, whatever it is, trying that, and I was feeling so sick over the weekend, there's just no way I wanted to start up another chemo. Therefore, we just kind of, I'm still doing the ADT, but we kind of put a hold for 3 weeks on starting some more. He was talking about maybe 2 sessions, and it would maybe bring my PSA low enough to go into immunization type therapies.
Mm-hmm, mm-hmm.
But I wasn't quite ready. That was kind of a surprise to me. We just talked about it. Next thing you know, he had me scheduled for it. And my wife's leaving for the week, take care of her mother, and just then we're colder than hell and everything else. We just decided it wasn't worth signing that up right yet.
Well, if he's talking about cabazitaxel or Jevtana,
you just mentioned Taxel, and it wasn't the docetaxel, it was the other one.
It might have been cabazitaxel.
Yeah.
And if he's talking about cabazitaxel or Jevtana, the experience, again, purely anecdotal from what guys I know who have done it and what I've heard, most guys have found that the side effects are a lot less intrusive and difficult than the docetaxel. Not everybody, but many people have found that the Jevtana is a lot easier to tolerate than the docetaxel, than the Taxotere. So
well, I'm getting a scan on Wednesday. It's some kind of new scan, PT-CT scan. It's a brand new machine up here. You get an injection for 2 hours, and then they go. It's kind of like a bone, bone type thing where I don't know what they inject you with, but you wait 2 hours for it to go through your body, and so we figured we'd wait to see where the cancer is gone or what it's done in the last 6 months since I had my last scan. You know anything about this new PT-CT scan?
No, I mean, I don't know what PT stands for. I mean, there's a lot of scanning equipment. I mean, I need to know the agent, if it's a C11 or F18. I mean, it's the agent that's important. Okay. It's the dye that they put into you with this injection.
I think he's talking about a PET CT.
Yeah.
Positive emission tomatron and a CT.
Right, but I mean, that's not new. I mean, that's...
Might be new in this area, though.
It's new to them with the machine.
Yeah, yeah.
Or something, because I've never had one of these.
But again, you know, it's a question of what agent they're putting in. Because they put an agent in that the machine picks up.
Yep.
And it's the agent.
Plus they put in that, I assume that stuff right as you go in the machine that gives you a contrast or whatever it is that makes your body heat up. And
yeah.
So I'm getting one injection 2 hours before and one during.
Right. So again, it depends what that injection is. I know you didn't have any luck with the genomic testing. How long ago was that you did the genomic testing, Frank?
About 6 months ago.
Yeah. And they did it.
And I talked to him about redoing it, and he just kind of poo-pooed it. He said it just wouldn't, insurance probably wouldn't pay to do it again. And there were just mistakes made. So that's why they never got the original biopsy off the tumor. I got the blood test instead.
So when you sent it down, you sent the blood work. You sent for a liquid biopsy. Is that right?
Well, we tried to do a regular biopsy, and they missed the cancer, and then we tried to do a liquid biopsy, and they didn't send the paperwork in right, so we basically wasted about 3 months trying to find out what they were supposed to and not supposed to do. So when they finally got it done, I came back with no markers, no genetic.
Well, was that because the samples were not good, or was that because there wasn't anything to be seen?
There wasn't anything to be seen. He didn't get the biopsy right, even though there's CT guiding it.
Okay, so but hold on a second. What was it that they analyzed? Was it a bone sample of the tumor? Was it a solid tumor sample they analyzed, or was it your blood that they analyzed?
Well, in the end, we went with a blood test because we weren't having much luck with the biopsies, and they didn't want me to do another biopsy.
Okay,
I did bring it up.
Okay, so to be clear, they did a liquid biopsy, and the liquid biopsy didn't show anything, and the liquid biopsy was done on a timely basis. Is that right?
Yep.
Okay.
Which is probably why the Xtandi helped me. It helped me for about a year. I got a year out of Xtandi.
Well, but the Xtandi's got nothing to do with the liquid biopsy.
Okay.
I mean,
I thought it could tell. I thought it could tell with certain things weren't worth.
No, that's a different test. That's called the ARV7 test.
Okay.
So my point is that I would open the discussion again with your doctor about getting, especially after they've done this PET scan, about getting a solid tumor analysis.
Okay.
Because the liquid tumor analysis, the liquid biopsy has a panel of about 60, and the solid tumor has a panel of about 360, I think it is, or 315. And it's a much more comprehensive test. And, to say he poo-pooed it, well, maybe he feels that because nothing showed on the liquid biopsy, nothing would show on the more extensive biopsy, but that's not the case. I mean, something may show. And if he doesn't have a better idea for treatment, if it were me sitting there, I would say, I want a bone scan. I want a proper bone biopsy done, and let's find a spot based on this most recent PET scan, CT scan, where we can get a decent solid tumor biopsy, and we can send it down.
And this has nothing to do with insurance because Foundation One pays for it, so I didn't quite understand what he was so concerned about. That why do another one? It was his opinion. And I got a new oncologist I see because my guy's retiring in 2 weeks, and I figured I'd bring that up to him and see what his thoughts are.
Well, I mean, I understand where he might be coming from, Frank, in terms of nothing showed on the liquid biopsy, so why bother with a solid biopsy? But the solid biopsy is a lot more comprehensive. Again, I give you the same advice that I said to Skip. Listen to the second hour of that presentation we did.
Okay. Well, it makes sense. I brought it up last time, and I just got blocks in the way, wall in the way, so with the new guy, it might change.
Yeah, well,
I want another biopsy.
When you get blocks in the way on something like that, just give us a call, and we'll figure out a way to give you ammunition or to bring around I mean, that's what we do. That's why we're here. Because they shouldn't be putting blocks in the way. If they're putting blocks in the way, it's because they can't be bothered.
Yeah.
And we want to do everything we possibly can, especially in your situation where, you're looking for the next treatment. Now, another thing that might be an idea to raise with the oncologist is seeing what you can get out of enzalutamide if you go back on enzalutamide now, for two reasons. One is because you had a bunch of testosterone pumped into your body, and it may have wakened up the androgen receptors, which is the Johns Hopkins way that they're doing it. And the other is because we do know that some people, even after they fail the drug, when they come back a year later, will get more time out of it.
Okay, you're talking about extending, right?
Yeah, that's what you got a result from, right?
Yeah. Well, yeah, it kept me down for almost a year, and then it started raising very slowly, like maybe 0.18 or 0.16 each time until we tried the bipolar, and then it really started falling.
Well, you know, my thought would be to do two things when you see this new guy. One, to go in and say, I want a proper solid tumor biopsy done so that we can do an analysis. And two, or three things. Two, to consider the cabazitaxel. And three, to think about going back on Xtandi.
Okay. One thing I noticed about in case anybody's interested, but the guy left, about the bipolar, and it may have had something to do with the testosterone. It didn't, I mean, none of it made me feel better, but for the final 2 weeks where you're not on anything, I felt worse than I did for the first 2 weeks on stuff. And it may have something to do with having more testosterone, which my body hasn't seen for 3 years or not. I thought that was kind of strange.
You're saying that you felt worse at the end of the 2 weeks than at the beginning of the...
Yep.
Well, didn't on the first one you took, you felt rotten right off the bat, didn't you?
Yep. I didn't feel very good. And like I say, when I was surprised when the 2 weeks came up, I felt just as lousy, and then started getting my taste buds back and my appetite back, and then they started me off on it again. So it just seemed like something was worse feeling as far as my body feeling after the 2 weeks was done on the 2-week protocol, when you're not on anything else after that. My oncologist told me that the testosterone only lasts for a couple days, 8 days, something like that, because it's burned off, and that's why you're only taking the etoposide for 2 weeks. And then the ADT is supposed to come in on the rejuvenated cancer cells and kill them off. But obviously that's not the case in my case.
Well, I mean, the
ADT
isn't going to kill them off right away. I mean, that's the discussion we had at the beginning of the conversation.
Yeah. Well, PSA started going up right off the bat. So I was having better luck, even though Xtandi wasn't working as much. It was still slowing down the cancer versus this bipolar thing.
And anybody else have any suggestions for Frank?
Rick, this is Len. I'd like to ask Frank, are you still in that bipolar trial?
No.
You're out because your PSA went up.
Well, no, it's not really a trial because it's already a finished trial or something. It didn't involve a whole lot of people. It was only like 14 people out of University of Washington, but it was only supposed to be a 3-round. They never called it a trial, so I don't think it was a trial. And then the people out east are only doing the testosterone, not the etoposide. And that was where I was supposed to end up, is just being able to use testosterone to open up the receptor cells and then kill them off with the ADT. But that never got to that point.
Well, Len, this was just copied a trial. This copied a phase 1 trial, I think, that they were doing at University of Washington, at Seattle Cancer Center. So Frank was never actually in a trial. The guy was just copying the protocol.
I see.
Well, he's tied into University of Washington, so
So it was not a formal trial. I mean, Frank never signed papers and all of the rest of the stuff.
No.
The guy was just following a trial. And what happened, Frank, what happened back east is as I understand it, is that they would put you on high levels of testosterone followed by either abiraterone or enzalutamide. And then they would keep repeating that cycle. I don't know how many times. So for you, they were using etoposide, and there they're using abiraterone and enzalutamide.
Okay. That's what I figured. I'd go back to enzalutamide at some point, but we're not there yet, and I just soon have the scans in and sit down with a new doctor, not try it with the old doctor.
Well, I mean, you are there. I mean, that's the point. You are there, but yeah, get the scans by all means. But you are there, so because you got to figure out something else, and maybe as we said, maybe the enzalutamide, the Xtandi will work.
Okay.
Anyone else would like to talk to Frank?
Frank, this is Jake. While you're on the etoposide and the bipolar testosterone, did you continue getting ADT, Lupron, or Firmagon?
Yes, Lupron.
You never stopped that?
Never stopped it. I'm on 3-month shots, not 1-month shots.
Okay. And when you went to...
I'm not sure why I'm on the 3-month shot, because I see him once a month anyway. But
okay, I think there are several trials going on. One that Rick mentioned is the enzalutamide or abiraterone and the bipolar. Another one was just to give you a high dose of testosterone, and then at the end of the month, it basically would wear off after 30 days or so, and then but it would re-energize some of your cancer cells to make them susceptible to the ADT that you continue to take all along. And so, and apparently they had some great success with that from the studies that I've seen. It's just, unfortunately, it sounds like in your case it didn't work. There's never 100% response to any of these trials, unfortunately, and you're just one of those who didn't respond.
Well, the trial out of University of Washington was a very small, like 14 or 16 person trial, so I don't even know if that was a legitimate trial, so to speak, because they dropped 2 of them out, so you're only left with 12 guys, and that's not a very good round basis to make any decisions on anything.
No, but that's typical for a phase 1 trial. I mean, it's basically to test the procedure to see if it's worth pursuing, Frank. There are different types of clinical trials, and most of the trials we talk about are phase 3 trials, which are the widespread ones with large samples. But before that, there are phase 2 trials, and before that, there are phase 1 trials. So a phase 1 trial may well be a very small sample like that. You can't base a lot on it, but it's essentially done to make sure that the procedure is safe.
By the way, my wife read in the paper yesterday, or it came up on one of her websites, is one of the new immunization drugs that was just about ready to get approved. They pulled it because it didn't help anybody. They saw no change in the effects.
Mm-hmm.
Which one was that? Please don't tell me it was Prospect.
You're not quoting me correctly.
Well, what do you want me to quote?
I don't want you to quote me at all.
Okay, I'm not quoting it correctly according to my wife, but she's the one that told me this to begin with, that they were pulling a trial on the immunization drug, though.
Do you remember the name of the drug?
It wouldn't be Prospect, Jake. Don't worry.
I'm hanging my hat on that one.
Yeah, well. Yeah. I'm not sure it's wise to hang our hats on any of these drugs, but some of them are going to work better than others. But I'm almost sure it isn't Prospect, because if it was, we would have heard about it. It would have made more of a noise within the community.
Right. Yeah.
Exactly.
I think you're right. I like the idea of Prospect because you don't have to go through the apheresis and all that kind of stuff with the blood transfusions and everything, you know, just basically a shot off the shelf, which is my idea of medicine. That's why I'm hanging my hat on it, hoping and hoping.
Well, it worked for about half the guys. It stabilized their this bipolar thing, stabilized or lowered the PSA about half the guys. But like you say, it's a very small sample.
Right.
So didn't do me a damn bit of good.
I wonder if the etoposide itself might have been the factor that caused the rise in the PSA.
I don't know. I mean, this is just the protocol they were using. Like I say, out east, they just use the testosterone without the etoposide.
Well, that's what I'm thinking. Maybe, you know, it might be worth trying one more shot of the testosterone without the etoposide.
Hold on.
Just an idea.
Yeah, but I think you've got to follow trial protocols. And for people just to be taking testosterone, it's not something, first of all, I'm not sure we should be suggesting in all good faith. But secondly, you know, the trials that I've seen well, I mean, they haven't just been testosterone. I mean, I would like to see the trials where they've just been giving testosterone and they've gotten a response. Because men eligible for these trials are all on long-term hormone therapy.
Right.
So we know that everybody that's going into these trials is already getting some form of LHRH drug. Now, I haven't seen any trials that have said just giving somebody testosterone is successful, although they've been trying that for years and years. There is a theory, a philosophy that it wakens up the androgen receptors, but to the extent that it does that, it makes you more susceptible to the second-line androgen drugs, which are a lot more powerful than the first-line ones. So I'm not saying it wasn't out there, Jake, but you know, maybe when you got a moment, you can send me the trials where they just used the testosterone and nothing else for men that were on long-term hormone therapy.
I'll see if I can find it, Rick. I'm not sure I can, but I'll try.
Yeah, I mean, the only two trials I'm aware of is the protocol that was which is the one that Frank followed, with the etoposide, and the other one, which is more common, which is the one that's being done at Johns Hopkins with Antonarakis, and I forget the name of the other guy there, where they're giving you testosterone. I think it's 1 month on, 1 month off there, I think, but I honestly can't remember. I just have to look to remind myself. And then they're following it up with one of the second line anti-androgens. But they're following it up with something, and they're not just giving you testosterone and they're not doing anything after that.
Well, what do you think the point? What is etoposide? He first told me it was a oral chemo, and then he told me it wasn't. So I kind of missed what the point of the etoposide was.
It is an oral chemo.
Yeah, it's an oral chemo, yeah.
Okay.
Do you know how it works, Len?
Well, it's what they call a cytotoxic. You know, it's a DNA, causes DNA damage in the cancer cells. I believe it interferes with the mitosis, the division of the cells. So, of course, it's going to affect any rapidly multiplying cells in the body, whether they're cancer cells or not. They could be mucous membrane cells, hair cells, you know, all of that stuff.
So I've noticed that I've had head cold for about 3-4 weeks.
Yeah, it affects the
Another
bone
thing
marrow.
The other thing that came through as far as side effect was that I've got very tender nipples. They're not growing like boobs or anything, but they're a little lump behind the nipple, and they're very tender when you rub your arm across them or something like that.
Mm. And you're not on, are you on Casedex or not?
No.
Mm.
This only happened since I started the
The
topicide.
topicide? I don't know.
Yeah, now that I'm off it a month, they still haven't gone away.
Well, talk to, you need to talk to the doc about that.
No, I did originally. He just felt them and just went, huh. So that's why I'm kind of waiting for my new oncologist to clean
Sounds like a
off.
plan.
Yeah, why mix two of them up at the same time?
Remind Lisa that we have a caregivers call tomorrow at it's at 4 o'clock Pacific.
Yeah, she's heading to California tomorrow. They're kicking her mother out of a care facility because she's got partial dementia and personality disorder, so they got to move her out.
Okay.
I think that's interesting. They kept her 3 months worth of money and $18,000 to move her in, and just decided to kick her out. But she was causing a lot of trouble. So when she gets back on Thursday, we all have had my other scan and hopefully make a new appointment with a new doctor and go from there. So she won't be on your thing tomorrow.
Okay.
That's enough about me. You got other guys to have questions, etc.
I do think, the only other thing I just wanted to leave you with is, again, it may be time to check in since you've got to make some changes. It may be time to check in with somebody like Schultz or, I know that you weren't thrilled about UCSF and Ryan, but Schultz might be a good alternative for you at this point.
Okay.
Or Jeffrey Turner, who's in the same practice, who I thought was very good.
Yeah, they're both excellent. We'll spend as much time with you as you need, not as much time as they want to spend, but whatever you need. And you can communicate with them by email afterwards. You can call them. They're just really tuned into you once you establish a relationship with them. There's and I was listening.
I didn't find that with Chuck Ryan. Chuck Ryan had me scheduled for about 3 o'clock and didn't see him till 5, and everybody else was leaving, and it was real quick and long trip for just that.
Yeah. Well, I this is Skip speaking, and I usually get in right on time. Maybe 5 minutes I have to wait, and you go through all the usual stuff with the nurse assistant and so forth, the weigh in and everything, and then you're in the office and you maybe wait another 10 minutes for the doctor, and then you have his attention for at least an hour. And you come prepared with all your questions and your research, and you get their undivided attention. It's well worth the effort if you can make the trip.
No, I got you. It's just down there. After a 2-hour wait, we saw the PA, and then Chuck Ryan came in for about the last 10 minutes of it. It was a question of whether or not with my intestinal problems I should do chemo, and he said, yeah, by no means do chemo. And that was basically just the visit. And sure enough, chemo wrecked my intestines quite a bit. We tried to call Chuck Ryan about it. He said I wouldn't worry about it, and that was the end of that.
So that was my first experience with chemo. In fact, I had developed a terrible intestinal reaction to my first round of chemotherapy, and we called Dr. Schultz's number. My wife did at 2 o'clock in the morning. Got the exchange, and honest to God, within 2 minutes, Dr. Lamb was on the telephone talking to my wife, and then they got me to the emergency room and found out that, because I guess my white blood count had dropped so dramatically. This was 2 days, I think 2 to 3 days after my first chemo. And I was in there with a massive colitis infection. And so they treated me for that. So, the chemo can cause all kinds of things, or maybe it allows things that are festering on their own just to come to the surface.
I'd had this problem for quite a few years.
Yeah.
And
Okay.
I was really concerned about it making it worse. Sure enough, anything I've put down there since, drug-wise, since the original ADT has affected it all.
Yeah. Well, if there's a way, if there's a way to manage it, you know what you're dealing with, and if there's a way to manage it, you do the best you can. But Rick is right. You ought to talk to Dr. Schultz if you even if you just want to have a consult, one consult. It's always nice to have get the opinions of another doctor who's well regarded in the field.
I think Dr. Schwartz out of Washington University is quite well respected.
Yeah. I mean, you could also go see him, but I do think that if you're in a position right now where you may want to, you're having to switch doctors, I think I would start with somebody a little further afield than Idaho, so you can get that genitourinary medical oncologist on board on your case full time, and somebody willing to work with a local doctor.
Okay.
Rick, when the conversation about the being treated with the high levels of testosterone, I think there's a doctor in Los Angeles by the name of Leibowitz who does that as well. I don't know how familiar you are with him. And
I am. I'm pretty familiar.
Yeah.
I'm pretty familiar with him, Skip, and I wouldn't refer anybody to him personally because I've seen how he treats people. I don't believe anybody that gives chemo to men who have low-level disease is a doctor that I would want to be referring anybody to. And he has some very strange practices. He's used testosterone in certain ways, but I'm not a fan of Bob Leibowitz, largely because I see him give chemotherapy to people that don't have high risk or advanced disease, and there's a guy up here who got chemotherapy with 3+3 disease. I think that's criminal, personally. But
as I say, I never considered using him, but I recall early on in my research learning that he uses high doses of testosterone with chemo and ADT, everything at the same time. And
well, he does, and he does it for people that don't need any treatment at all.
Yeah.
And then these people are cured, and they think that he's God, and the fact is they probably could have gotten the same results on active surveillance.
Yeah.
So,
Rick?
Yeah.
For those who are online, I did post a link to, it was a summary in Science magazine. Not the actual, the trial results, but it's a summary.
Mm-hmm.
And the guy from Johns Hopkins is named Schweitzer.
Schweitzer, that's it.
Yeah.
No, wait a minute. Is Schweitzer at Johns Hopkins or is Schweitzer at...
I'm sorry, he's at the
University of Washington.
Yeah, Schweitzer's at University of Washington. There's another guy at Johns Hopkins.
Working with Hopkins, right.
It's Antonarakis, and then there's one other guy there whose name I forget. I forget. But again, I'll look at it. I'll look at it after. But I think that in each case they're doing something after the testosterone. They're not just doing testosterone on its own.
Well, if they are, they didn't mention it in the article.
Well, I know Schweitzer is doing etoposide afterwards.
Yeah, but then there's something about once you've done the 3 rounds, just doing testosterone with the ADT
Yeah,
by itself.
yeah, but
if it was-
yeah, but you've got to do something first. You know, I mean, you've got to do something first. And again, I mean, and also this is obviously written by a journalist, so we got to look at it, and it's got to be read carefully. Len, your homework.
What's that,
Len,
Rick?
I said
Yes.
your homework, man.
What's my homework?
The link that
That I put up?
no,
Or
the
that Jake
link
put up?
that Jake just put up.
Oh, okay.
No, I mean I'll certainly look at it afterwards. What was the link that you put up, Len?
Well, I had a feeling that this is what Frank's wife was talking about, the new prostate cancer info link. Just at 9, at least at the time I received it was 9 o'clock this evening. It's entitled Immunotherapy for the Treatment of Prostate Cancer, and I'll just read the first sentence. The Society of Immunotherapy of Cancer has just issued a detailed statement on the role of immunotherapy in the management of prostate cancer.
Right. No, that's not what Lisa would have been referring to. That's something that he posted earlier today, which is an article that really evaluates Provenge and Prosvac and not much else. I haven't read it in detail. I just read the abstract, but I got to read it. That's not about treatments that do not work. I mean, what they do say is that there isn't enough evidence right now for some of the personalized drugs, but they don't say they don't work. They just say they haven't done enough trials on them yet.
Okay.
But we know that. I want to welcome Mr. Foodie, who I see is on the call.
Our resident thespian.
Our resident thespian, yes. Your fan club. Your fan club is in the meeting, Mr. Foodie. I don't.
Hello, Richard. Happy New Year.
I think he must.
Well, what happened to him?
He must have stepped away from the mic.
Oh.
Maybe he's singing in the bathroom. He may be back. He may be back.
Okay.
No, I mean, we'll look at it after, but I'm pretty certain that all of these, well, what's going on there?
That's
Can you hear me now?
Yeah, we can hear you now.
Okay. It's interesting, anyhow. I thought I could talk into my laptop, but I actually have to talk into a microphone that I plug into the laptop.
Well, there you go.
Yeah, so there you go. So, Happy New Year!
Happy New Year! Happy New Year! How have you been? We haven't heard from you for a while.
Oh, I've been good. I've been very busy. From the show, which went very well.
Yeah.
To the church choir, we had a benefit concert, and then the Christmas, masses and things like that. So it went from like one production to another.
Yeah.
And I had my 3-month follow-up in November, and and I got a job.
Oh!
Yay!
Congratulations!
Thank you.
Speak to us.
I'm working for Hallmark Cards now.
All right. Full time?
No, it's part-time, but I'm an employee of Hallmark with an official Hallmark.com email address.
Okay.
And I work in retail marketing and merchandising, but I'll tell you, man, I was out for a long time, and it's great to be working again. It's wonderful. My God. Oh, my goodness.
And everything I hear, Hallmark is a great company.
It is. I mean, I love the products. I've had 2 executive teams come through one of my accounts, and they talked to me, and I got great feedback and on both visits, and there was happiness and smiles, and it's just been a really good experience, and so I'm very grateful and very blessed that I got this job. Boy, it was a long time, and
It
Yeah,
was. It
well,
was.
congratulations. That's exciting.
It was a long time coming. It was a
yeah.
long time coming. I want to know something. After the executive team came through and they gave you such good feedback and patted you on the back, did they send you a card?
Well, as a matter of fact,
Yeah.
one of the vice presidents did. The second trip through the store was with the CEO of. So Hallmark is it's a corporation, and then they have different divisions, and each division has its own CEO.
Yeah.
So the second trip was the CEO for the retail merchandising division, and the CEO is accompanied by a VP of mass services for mass merchandisers, and this was at a Walgreens account. I work in national accounts, and he sent me a thank you card, and he said that with a gift, and he said that the contribution to retail services is highly visible.
Fantastic.
And yeah, so or your contribution to retail services is very visible, something like that. But that was wow. I
Very
couldn't get
good.
over
Well,
that.
listen, you better make sure you comp all these high executives tickets for your next show. That's all I can say.
So
Now, listen. More important, what did Dr. Radkoff say to you at the last, and where was your PSA? And give us a little update on your medical situation and your meds and all the other good stuff.
okay, well, I'm prostate cancer, incurable. I'm receiving hormone deprivation therapy, Lupron, Zometa, and Xtandi. And I also take vitamin D, to help strengthen my bones, and I've started taking vitamin B12 because my red blood cell count started to decline. And I just mentioned that. So in November, my PSA had, which had fallen back from 0.31 to 0.28. My bone mets or my bone scan and CT scan said everything's there's no change in the metastases in comparison to the scans 2 years ago. And however, they did notice some spots on my lung, and I've been working with a pulmonary oncologist because of shortness of breath, and I didn't know whether that was related to my medications that I was taking, which is a stated side effect, but it's the shortness of breath is really a function of being a smoker, and I stopped over 2 years ago, but everything they say about it stays with you. So I've got COPD, and anyhow, so they don't know what these spots are. They've ruled out tuberculosis. They've ruled out Legionnaire's disease. Dr. Rathkoff is a wonderful researcher, so she did blood work, and there were things that she measured. I have no idea what they were, but there's this impressive list of things that they measured, and the pulmonary oncologist is a clinician, and so she's approaching it a little bit differently. But I've got it. Boy, I am so lucky that I've got these two doctors working with me and monitoring this, and so I go back in January or February for a follow-up. But whatever it is, they're on top of it in the beginning. So and they're deeply concerned. When Rathkoff told me, God, I thought she was going to cry. So because I've been doing so well, and she was just devastated by this. So and she was also very proud of my my work in the shows and on the Dragon Boat team, and then to see this, she just didn't quite know how to handle it herself. So it was very interesting. But
did Dr. Radcliffe come and see you in the show?
no, she didn't. But she was very supportive, and she, when I told her I was doing it,
Yeah.
oh, she just stood up. She said, "I am so proud of you," and with a big smile. And
we're all proud of you, Mr. Foodie. You know that.
Yeah, yeah. They Robin Roberts did a webcast. I forget what it was called, and I was one of the people interviewed from Memorial Sloan Kettering on video. And they chose one of the other Empire Dragon Boat team members to be featured in this particular web broadcast on integrative medicine. But they still have my footage, and they really liked my footage. And Memorial Sloan Kettering has asked me to be profiled in their Bridges newsletter in the spring.
You are a media star between the show business and the athletics and everything else, man. You are the media star.
Well, Reluctant Brotherhood, I still like to call it Reluctant Brotherhood.
Okay.
You're going to get a mention in Bridges for sure.
Oh, mention us as Answer Cancer, though. Would you now Answer Cancer? Give us a mention, but you've got to mention Answer Cancer and Brotherhood, otherwise.
Okay, because this is a way of reaching out to guys. Donna was actually the one, she nominated me, and Donna Wilson.
Yeah.
I think secretly she wants this to appear so that we can help recruit guys for her Dragon Boat team. And, but
so those of you who aren't up to speed, Donna Wilson is in the Integrative Center, and she's an exercise. She's an exercise therapist. She's an RN and an oncology nurse, and also a personal trainer. And she and Richard have been working closely together now for 2 or 3 years. And she's also quite a remarkable person. And so that's the Donna Wilson background. I have a question for you. I was just looking at my notes on you. You're back in February of 2016, your PSA I have as being 0.19. How high did it get? Because you said it came down from 0.31.
0.31 was the highest it got.
Okay.
And that was in August.
Okay. So that's interesting. So in other words, you started to see it go up on Xtandi, but then it turned around and came down, huh?
Yeah, and I'm still taking Xtandi. It's over 2 years now.
Right.
And so Donna thinks that Donna thinks it's the exercise that's helped me, and the Dragon Boat team. The not only the racing but the training and the practice. The intensity of the workouts. The workouts are very intense. So my body's functioning at a higher level, and so she believes that the more active your body is, the more endorphins are released, and the more your immune system is functioning. And I increased my protein content to 20 to 30 grams per meal, and that was something that another health counselor had recommended. And I've also increased my red blood cells have come back up since I've been taking B12. So that's good. Now, one thing that I did, which is extraordinary, on the Dragon Boat team, there's the Empire team, which is breast cancer survivors and all cancer survivors, and then there's a second group called the Memorial Sloan Kettering Dragon Boat, and employees of Memorial Sloan Kettering, and I've had the honor and the privilege of racing with them on their team twice now in Richmond, Virginia, and Hartford, Connecticut, because they were short paddlers. And I befriended one of the paddlers, and she's a research PhD, and she's working on cancer immunotherapy. And on the ride down to Richmond, we were talking about my cancer, and she was talking about her work, and I said, wow, it'd be fantastic to see it if that's possible. And so she arranged a tour for the Empire Dragon Boat team to go to their laboratories and see what the research firsthand, what they're doing with cancer immunotherapy. And so her boss made a presentation, an overview of what cancer immunotherapy is, and I'm just going to simplify it, but basically they believe that the body's immune system can have a significant role in combating or stopping or slowing cancer. Cancer is invisible to the immune system, but they're trying to find ways to make the cancer cells visible to the immune system, and then let the immune system do what it does best, which is naturally just going after and attacking and destroying unwanted things in the body. So they're engineering T cells. And this might not be perfectly technically correct, but just for the sake of this discussion, so the T cells is one of the key cells in the immune system that goes around, seeking out bad bacteria. And
let me interrupt you.
Yeah.
This essentially is what they've been doing with Provenge. You've heard of Provenge, right?
Yes.
So this is essentially what for prostate cancer. This is what the Provenge research is. So
Okay.
I don't know what cancer they're doing this for. What's the name of the company?
Well, this is Memorial Sloan Kettering.
Oh, this is at Memorial Sloan Kettering.
Yeah, Memorial Sloan Kettering. Yeah.
And so this is.
So they're working on breast cancer, prostate cancer, the blood cancers. They've got different groups working on the different cancers. So I think they're having the best success with the blood cancers.
Right.
And so now they're going for breast and prostate because that's two very large groups of people that get cancer. So after the presentation, they took us into their laboratory, and Vander is the name of the person who is the dragon boat paddler. So she's been working on this research project for 3 years, and she's trying to prove something is right. And there's somebody else that's trying to prove that she's wrong, and that's how they do the research. Someone tries to prove that they're right, and there's somebody else that's trying to prove that they're wrong. They have these cells, and they have to feed the cells every 2 days with glucose. They've got these petri dishes filled with cells. So in one of the labs, we got to see engineered T cells, and they were in a petri dish, and they put them in under a high-powered microscope, and we got to look into the microscope and see these T cells swimming around in the petri dish. And then in the next lab, there was a petri dish with prostate cancer cells, live prostate cancer cells. And they're moving around, and they're moving the microscope in and out so you can see them, pretty close up, and then at a distance shot, so you get a sense of how they look in your body. And then in the third station, they had a petri dish, and they introduced the engineered T cells into a petri dish with live prostate cancer cells, and you could see the T cells coming in, and they're sort of hanging out on the left because that's, I guess, that's when they, that's what it appeared like under the microscope. And then one or two of them started going over to the prostate cancer cells, and then the others started to follow, and it was like, I guess it was like rugby, where they just pile up, and I was watching the T cells beating the hell out of and out of prostate cancer cells and destroying them right in front of my eyes under this microscope. Unbelievable, just an unbelievable sight, and that's what they do in this laboratory. So it was extraordinary to see that, and so they're trying to find a formula that works for everyone, but they have to start someplace, and I didn't get all the details about which one that they were working on, but anyhow, it was just wonderful to walk out of that laboratory and saying I saw prostate cancer cells being beaten up and destroyed by engineered T cells, and so that's what I talk to my body almost every day, and I tell my T cells to go after them, find those invisible cancer cells and go and beat them up and destroy them. So
I have
they're not
I have a very, very, very close buddy, my closest buddy really, who's an oncologist in the UK. And many, many years ago, when he was in med school, he used to write songs for a medical review.
Yeah.
And I have to find out whether any of the, and they just did I think on their 40th anniversary of graduating, they just did another concert. The group, they called themselves the Manic Depressives, and they still go by that name. They still put on shows for students today. I got to write him and see if he's done any songs about T cells. If he has, then I'll get the lyrics and we'll share them. And I'll send you the lyrics and the music, Mr. Foodie. You can perform for us. Anyway, guys, look, it's 4 minutes after 7. We filled up another couple of hours. Don't forget to tell your significant others that we have a caregivers call tomorrow if they would like to join us. And the next call will be on Tuesday of next week, and we'll be well into the year by that point in time. So, just one quick question. I haven't used a microphone today. I haven't used headset because my headset microphone isn't working. Could everybody hear me okay, or do you feel that it's better do I need to replace my headset?
Nope, better than ever tonight, Rick.
Nope.
Okay.
Yeah, very, very clear.
Okay.
Yeah, very clear.
We're very clear.
I'm not going to bother replacing it then. All right. Listen, Happy New Year, everybody, and we'll speak to you next week. And anybody, like I've said, please follow up with me if you need to, Ben or Skip or anybody else. Okay.
Right before you go.
Great.
Happy New Year.
Thanks, everybody. Happy New Year.
Happy New Year. Go ahead, Jay.
Sam Denmead was the other guy.
That's right. Demi. Yeah.
And I did post two links, two science articles for you.
Yeah. Okay. Thanks a million.
Okay, have a good one. Thanks again.
Bye.
Good night.